Today, we are going to talk about a very interesting case scenarios which are related to renal tubular acidosis, especially distal RTA. So RTA is one condition which is often underdiagnosed and associated with significant morbidities and mortality. And what we'll show today is the whole spectrum of how distal RTA can present at different ages and how we need to have a higher index of suspicion to identify at the right time. What will happen if you don't identify at that time, how they can develop a lot of renal complications, skeletal complications, muscular complications. So the overall concept of this grand round would be to go through case scenarios to highlight when should we suspect them, how do we have inputs in terms of various combinations in terms of clinical parameters, and go from there. In the name, it is renal tubular acidosis. So you need to have acidosis number one. This acidosis has to be metabolic. And this has to be a hyperchloremic metabolic acidosis along with a preserved glomerular function. That is what RTA would be. Now, there could be certain situations where this RTA diagnosis may be confusing, as was this 4-year-old boy with rickets who presented with hypocalcemia and whose potassium was on slightly lower side. Workup showed phosphorus on the lower side, alkaline phosphatase was high. So these were the presentations, and then the treating physician did a blood gas which showed a mild metabolic acidosis and an anion gap which was normal. So this is hyperchloremic metabolic acidosis with a normal anion gap. Do you agree that this is RTA?
The thing is that it is basically normal anion acidosis, but the potassium levels are actually.
So there is no hypokalemia. So do you need to have hypokalemia in everybody?
No, sir. In proximal RTA, at the time of diagnosis, it might be in the low normal to the listing. So still it is a possibility, but we need to look for other things also. We need to look for the height, weight, and the other parameters.
So you have to look at the urinary anion gap, and we'll discuss about the approach in detail. Now, what we are really looking at is that urinary anion gap was positive, which means that the ammonium production was defective. So this goes more in favor of RTA. Urinary pH was on the acidic side. So you had acidic blood, acidic urine, diagnosis of distal RTA. Now, do you agree with distal RTA diagnosis here or not?
Sir, the thing is that it is a rickets. First of all, we have to consider RTA in case of refractory rickets. Sometimes rickets would have vitamin deficiency, which can lead to hyperparathyroidism, which can also give us a picture of proximal
So
RTA.
I think this is a very important point that you have raised, whether it is primarily a RTA which is causing rickets, or you have vitamin D deficiency which causes secondary hyperparathyroidism, and that's why you have this RTA-like picture. Now, the pointers against rickets being primarily because of RTA is that the severity of RTA here is not that much. So what we looked at was that vitamin D levels were very low and the PTH was high. So this is a scenario in which you had low vitamin D with secondary hyperparathyroidism causing a Fanconi-like picture. So this is not RTA. So you need to have a very clear-cut situation where you need to do a blood test. Now, this is a very mild, minus 6.5. So you will get confused. So unless there is refractory rickets, do not do a proper evaluation in that regard, which is a message which comes from there. Now, Dr. Vibha, 12-year-old girl with multiple fractures, as you can see. And along with that, she had failure to thrive, polyuria, myopathy, early onset. There is significant metabolic acidosis. Bicarb is low and base excess is minus 14. There is hypokalemia at presentation. And if we look at the workup, we found anion gap was normal and it was clearly RTA, urinary anion gap was positive. Now, the question is whether it is a proximal or a distal RTA. Now, the workup which was done, which showed that the urinary pH was 5.8, which means
5.8 is like urinary pH is going in the favor of distal RTA, but
so you have a acidic blood, but the urine is still not acidified. So you're thinking of a distal RTA. But what was there also was there was amino acid urea, which happens in
proximal.
So is this proximal or is this distal RTA? Amino acid urea, as you said, happens in proximal RTA. And you have an inappropriately high urinary pH for the level of acidosis.
If there is this UTI or something, increase the
What is the clinical picture like? Is it like a proximal or a distal RTA?
Yeah, the presentation is very little. In the proximal RTA, presentation is very early, and there is like a
There is severe acidosis, which goes more in favor of a distal RTA. Fractures which are there, they go more in favor of distal RTA. So the point here is that why is there amino aciduria, which you have to explain, which can be because of same thing. So as discussed in the first case, secondary hyperparathyroidism can cause a Fanconi-like picture, which will cause phosphaturia, glucoseuria, amino acid uria, and that's why. So although we say RTA is very simple, that you look at the blood gas shows acidosis, which is hyperchloremic, the urinary anion gap is high, then you look at urinary pH and you say proximal distal, there can often be confusions which are there, and that's why we'll be discussing this in more detail from there, as seen by these two cases. You all can go and have a look at our website, learning.rosociety.in, which has got a lot of information about different aspects about pediatric endocrinology. We have got multiple validated courses which are available, including practical assessment. Especially, we have a fellowship program, which is a 3-year program with 2-year training and diploma, along with courses for postgraduates. We run 3 grand rounds every month in the form of one for postgraduates, one for pediatric endocrinologists, and one the PG lecture series. All 3 cover different aspects of case-based versus didactic teaching in that regard. Books are available from our website covering entirety of pediatric endocrinology, and our mobile application would help you in terms of achieving the right approach, including specific ones for metabolic acidosis and RTA, which are available. Now, as discussed by Dr. Manoj, renal tubular acidosis is basically a case of renal tubular problem causing acidosis, which is what there. So we need to understand a bit about the overall mechanism by which acidosis will happen. So in the body, we don't want the pH to become acidic or alkaline, because that is going to cause a huge problem in terms of the overall functionality. So there is a big buffer which is available in the body, which neutralizes this amount of these situations. So we've got proton and bicarbonate. Proton and bicarbonate under the influence of carbonic anhydrase forms water and carbon dioxide, which are then expelled through the respiration. So the most acute mechanism by which we handle acidosis would be to make it into CO2 and take it off from the lungs, which is the most common ones. Now, kidneys play a very, very important role because they regulate both the secretion of proton, which predominantly happens at collecting duct, and the reabsorption of bicarbonate. So while carbon dioxide ventilation issues will cause more of a respiratory acidosis, issues in terms of pumping out of protons or back diffusion, or let's say excretion of bicarbonate, will cause what is known as metabolic acidosis. What is the best marker of metabolic acidosis on the blood gas?
Standard base excess.
Yeah, which means
base excess at the bicarbonate 24.
Which basically means that, no, that is standard bicarb. So base excess would mean that how much extra base is there in the body. So if the base excess is negative, which would mean basically that you have base deficit. So base excess and base deficit, whatever way you want to put it. If you have a negative base excess, it means the body has a deficit of that. So standard base excess is the best parameter, and standard bicarb, which corrects for CO2, is another parameter which you should go ahead. Don't just go by pH and bicarbonate. You have to correct it for the level of CO2, which becomes important. So metabolic acidosis will happen either you have too much acid in the body, or the protons are not being able to taken out, or your bicarb is filtering out. So you are not able to pump out proton, or your bicarb cannot be taken back in the system. It's being lost in that regards. Now, gastrointestinal tract has got a lot of bicarbonate, especially the lower GI tract. So if you have a lower GI diarrhea, which is a chronic diarrhea, you will lose bicarbonate and you will again have metabolic acidosis, which will happen in that regards. So in this perspective, if you look at it, if your CO2 excretion becomes less, you will have respiratory acidosis because of a carbon dioxide accumulation. What will happen to the bicarbonate in that setting? It will increase. So what is the relationship between CO2 and bicarbonate?
For 1.5 HCO3.
That is for metabolic acidosis, for respiratory acidosis. So for respiratory acidosis, depending upon whether it is acute or chronic, your bicarbonate will go up by 2 or 4 millimoles per kg for every increase in terms of CO2 in that regard. So this is one mechanism by which you do that. But that's mainly for respiratory acidosis. So respiratory acidosis is high CO2, high bicarbonate, no confusion. Now metabolic acidosis will have a bicarb which is low and CO2 which is low. And for that, what Naveen was saying, the correction should be bicarb into 1.5 plus 8. So if your bicarb is 10, then your CO2 should be 23, which is an appropriate compensation in that regards. Now, metabolic acidosis can happen if acid is accumulating in the body in the form of ketones, in the form of lactate, in the form of whatever organic acids which are accumulating. These situations will be associated with increased amount of negative ions in the body, which would in a way mean that your anion gap, which we'll discuss more in detail now, will be increased in that setting. The second situation would be in which your proton loss is less or you are losing more amount of bicarbonate. These situations, your anion gap will not be affected because your chloride levels will also have a simultaneous change which will happen. So these are the normal anion gap metabolic acidosis, which basically means only two things: either it is renal or GI. Two other causes of normal anion gap metabolic acidosis, Dr. Vibha, other than the renal and GI. Which drug can cause that?
Carbonic anhydrase.
Yeah, carbonic anhydrase inhibitor, acetazolamide, and it's the same thing. Ureterosigmoidostomy. So if there is a ureterosigmoidostomy, you are losing, effectively you're losing through the same mechanism, but that will be the other one. But this, the history will be clear. So metabolic acidosis, high anion gap, normal anion gap, GI versus a renal loss, which will happen in that regards. Now, renal acid bed regulation basically is that you will be pumping out 1 millimoles per kg of protons every day from the distal convoluted tubules, and bicarb is filtered huge amount, around 70 millimoles per kg per day, but most of it is actually reabsorbed in that perspective, which is 99%. So either you can lose more bicarb or you can gain proton. Now, what will be the basic difference in the severity of acidosis in these two conditions? First condition, you're not able to pump out proton from the distal tubule, which is known as distal RTA. The second situation is that you're not able to resorb bicarbonate from the proximal tubule, which is the proximal RTA. Which one will be more severe?
At presentation, distal RTA will be more severe because there is a decreased capacity of H plus expression. So it is a cumulative process. In the proximal RTA, after some time, body stop excreting a bicarbonate.
So there will be a level at threshold below which you can't filter bicarb. So the problem there is that you will lose a lot of bicarb, but once your bicarb becomes like 15 or something, you won't filter anything. So that will be a self-limiting process, which will mean that proximal RTA is usually not very severe and often it is mixed. This is an important message to consider. Now in proximal RTA, because your bicarb excretion becomes not there because it's not filtering, urine will become acidic, pH will become less than 5.3 in that perspective. While distal RTA is unrelenting, you will keep on accumulating protons and this will cause a severe situation and your urine will never become acidic. So you will always have an alkaline urine. Now we know that distal RTA here is more severe and proximal RTA probably will be milder. But which one will require more bicarbonate? Dose.
So the basic pathogenic mechanism in case of proximal RTA is the bicarbonate loss. So in that case, we need to give more amount of bicarbonate. And even if you give more, it is going to be low. So the difficulty, there will be a much difficulty in management and the dose required will be higher in case of proximal RTA.
So as we talk about hypoglycemia, we say that if you have hyperinsulinism, where a lot of your glucose is being wasted, you need much higher glucose infusion rate. Same happens in the setting of proximal RTA. Whatever amount you give, as soon as it goes beyond 15, it will be lost. So for proximal RTA, you will find it that it is less severe, but your requirement will be 6 to 7 millimoles per kg per day. But for distal RTA, all after your initial correction is done, all you have to do is to just replace the amount of bicarbonate, which is like 1 to 2 millimoles per kg per day. So your ultimate requirement will be low in that perspective. A vast majority of bicarbonate is actually, so last amount of bicarbonate is actually lost in the proximal tubule, around 70 millimoles per kg per day. and a vast majority of it is actually absorbed at the level of proximal tubule. Now, proximal tubule is also absorbing simultaneously phosphorus, amino acids, and glucose. So if you have a proximal tubular dysfunction, you will have amino acid urea, glucose urea, phosphate urea. And I discussed that hyperparathyroidism also induces this state. So this is a classical Fanconi syndrome-like picture, which is there in that regards. Now, this bicarbonate is then some amount is also absorbed in the distal tubule, and only 1% will be lost in that perspective. So normally your bicarbonate excretion is very low. So if we want to assess whether your bicarbonate excretion is increased, we look at fractional excretion of bicarbonate. If it is less than 5%, it is suggestive of a distal RTA. If it's more than 10%, it is suggestive of a proximal RTA. What about protons? So protons have to be actively pumped out, because normally what we talked about is that you have to basically reclaim bicarbonate because it is freely filtered. Protons are not freely filtered. There are specific mechanisms like proton potassium ATPase and proton ATPase which will push this proton into the lumen, and this is a huge gradient which is being produced 1 into 250. And from here, proton may back diffuse also. So you have to be careful that it does not back diffuse in that perspective. And that's why you need to have convert it into ammonium ion. So kidney produces ammonia, which then binds to proton to produce ammonium, which will then take it out. So the proton excretion is much more complicated. It requires an active process, 2 enzymes and 2 exchangers, proton potassium ATPase and proton ATPase, and then ammonium production. And this ammonium production becomes important. So conditions in which this ammonium production is defective will result in a situation of acidification defect. And that is why ammonium production is considered to be a good marker of renal tubular function and acidification, which we'll discuss subsequently in that regards. So what will happen if anybody who has a normal mechanism develops metabolic acidosis? What will happen to the bicarbonate excretion? What will happen to ammonia production? And what will happen to the urinary pH?
Normal person.
Yeah.
In normal person, if patient develop acidosis, then urine should be acidic. There should be increased by ammonium production, and there should be 0 bicarbonate in the urine.
That is very, very important in that perspective. So if you are losing bicarbonate while you are still acidotic, there is a problem, which means there is a proximal RTA. If you are not able to increase ammonia production while you are acidic, it means there is an acidification defect, which is there in that regards in that setting. So this is how it happens. So what can be the causes of abnormalities in the tubular dysfunction? You can have a problem in the proximal region. As discussed, this will be associated with bicarbonate urea, phosphate urea, amino acid urea. This is a self-limiting condition. So proximal RTA, as soon as your bicarbonate becomes less than 15, you won't filter anymore. And in that situation, of course, this will be a self-limiting condition. There will be acidic urine and there will be no calcification. This is important. Why would there be no calcification? Is it because your urinary calcium excretion is less?
No, sir. Urinary calcium is almost same as compared to the distal. The thing is that because there's loss of citrate, which basically combines with calcium and takes it.
So there is no difference, and often people say that hypercalciuria, you can differentiate between proximal and distal. No. Anybody who has acidosis will have hypercalciuria. Now, because distal RTA have got more severe acidosis, they will have more hypercalciuria. But because citrate urea also happens in proximal RTA, that protects them from developing nephrocalcinosis. So nephrocalcinosis and not hypercalciuria are markers that distinguish between proximal and distal RTA. Now, distal RTA can happen if you have a problem which is there either in the proton potassium ATPase, proton ATPase, sodium exchanger. We won't go into that many details as far as genetic causes are concerned, but this is much more severe with alkaline urine and renal calcification. This is the basic difference which is there. Then we have a type 4 RTA, which is basically a problem in the epithelial sodium chloride channel or the renin-angiotensin-aldosterone system. It is associated with mild acidosis with hyperkalemia. And we discussed earlier that potassium and proton both will compete with each other to go out in the urine. So if you have hyperkalemia, you will lose potassium, proton will not be lost, you have acidosis. If you have severe acidosis, proton will be lost, potassium will go up. So acidosis will cause hyperkalemia. Hyperkalemia will cause acidosis, which is there in that perspective. So renal tubular acidosis can be distal, which can be genetic or acquired. Now, this is very important. We'll show you how it is important in one of our cases, particularly obstruction, autoimmunity can be important. This will be alkaline urine, which is severe, isolated with calcification. Proximal RTA is usually genetic, and it can be because of some drugs or toxins, usually associated with acidic urine, which is self-limiting with loss of glucose, phosphorus, and amino acids. There will be no calcification. And finally, we have a hyperkalemic acid RTA with voltage gate defect or a RAS defect. So I'll be focusing predominantly on distal RTA because all 4 cases we have chosen are all distal RTA, which is more common, more severe, and more likely to present to you with failure to thrive, calcification, fractures, or paralysis. Now, the question which you will ask is this child presenting to us having RTA? If it is RTA, whether it is proximal or distal, and then what is the exact cause in that regards. So if we go now in terms of when to suspect, and this we already discussed, so I would say isolated growth failure before 3 years of age, blood gas is essential. Rickets, refractory rickets with low phosphorus, think of RTA. Renal calcification, blood gas is absolutely important. Periodic paralysis, blood gas is important. Polyuria, before you work up for DI, do a blood gas, and if you have acidotic breathing. So these are the presentations which are there. Because the presentations are varied, you need to give a high index of suspicion for evaluation in that regards. This is what we said, that this is RTA. So you need to have a renal tubular acidosis. So it has to be acidosis which is metabolic with a tubular problem, normal glomeruli. So for RTA, you need to have a metabolic acidosis. So pH should be less than 7.2. Base excess should be below -5. So -6, -7, which means that there is a metabolic acidosis. On top of this, you need to have a hyperchloremic metabolic acidosis or a normal anion gap. We'll discuss about what anion gap exactly is, with a normal ammonium excretion, with the abnormal ammonium excretion as reflected by a positive urinary net charge, which we'll discuss, and a creatinine, which is normal. So what really is the anion gap? Now, we all know that there are different electrolytes which are situated in the cell or outside the cell. In the plasma, we are measured ions, which are mainly 3: sodium, chloride, and bicarbonate. Now, sodium is positive and chloride and bicarbonate are negative. As we are seeing that there is around 20 gap which happens in between the positive and the negative ones, and this is neutralized by what is the unmeasured anions which are the body. So this is what the anion gap is. So anion gap is basically the difference between the unmeasured negative ions versus unmeasured positive ions. If we go in other ways, we can say measured positive ion, which is sodium, minus measured negative ions, which is bicarb and chloride, will give you the anion gap in that regards. So it is unmeasured negative minus unmeasured positive ion. Now, if you flip the coin to the other side, simply you can, how will I measure the unmeasured? So in that situation, you look at the sodium, which is the measured positive ion, and chloride and bicarbonate, which are the measured negative ion. So the difference between them two is the anion gap. Earlier, people used to use potassium also, which is not being used these days in that regards. This is usually 10 to 12 millimoles per liter. Now, if there is accumulation of organic acids, Dr. Naveen, what will happen to the anion gap?
It will increase. It will be increased.
So if you have anything like lactate, ketones, or decay is the most common we see, organic acidemia, your anion gap will increase because unmeasured ion is more in that regards. What will happen if you have a loss of bicarbonate or if you have increased HCl?
In this case, it will be normal because there will be compensating increase in chloride.
So as your bicarbonate goes down, chloride will go up. As your sodium goes up, chloride will go up. So this will have RTA, and diarrhea will typically have a normal anion gap. So this is a very, very simple concept to understand. So anion gap is a primary investigation to classify metabolic acidosis. Then to differentiate, once you have a hyperchloremic metabolic acidosis, the next issue is whether it is renal versus GI, and therein comes in two measures by which you can classify. One is the urinary anion gap. Again, the concept is the same. unmeasured negative minus unmeasured positive. In other terms, it becomes a bit different. It is sodium plus potassium minus chloride. Because in urine, sodium and potassium are similar. In blood, it is 140 and 4. So we ignore that 4. So sodium plus potassium minus chloride. What will happen to urinary anion gap in diarrhea, Dr. Vibha?
So in diarrhea, there will be the normal ammonium means production. So the anion gap will be this negative side.
So basically what will happen, your unmeasured side will increase in that regards. So anion gap will become negative. What about RTA?
So this there will be the impaired production of the ammonium. So the anion gap will be positive.
So again, you will have a positive anion gap. So now we have seen that for RTA to be diagnosed, we need to have metabolic acidosis with a normal anion gap, with a positive urinary anion gap and a normal creatinine. This becomes the criteria as far as RTA is concerned. Now, another way of looking at this ammonia production is the osmolar gap. Now, osmolar gap means the difference between measured and calculated osmolality. Now, the major component here would be the ammonium. So we assume that the unmeasured urinary osmol is ammonia. So what will happen to if you have a urease producing, of course, your ammonia production will go up. So you need to exclude UTI in that setting. Now, what will happen in diarrhea to urinary osmolar gap? Because your ammonium production is more. So if you have an increased amount, you will have a diarrhea-like picture. It will be more than 400. What will happen in RTA, Dr. Manoj?
Because ammonium production is defective, so it will decrease to 1.4.
So it will be on the lower side. So two ways to differentiate a GI loss versus RTA is to look at urinary anion gap, which will be positive in RTA, and urinary osmolar gap, which will be low in RTA. Urinary anion gap will be negative in diarrhea, and it will be high in the setting of osmolar gap for diarrhea in that regards. Now, once you know this is RTA, now before we go for the cases, just to summarize, you need to look at whether it is proximal versus distal. So what would be the urinary pH? If you have anybody who is acidic in the blood, urine should always be acidic. So we say if you have dilute blood, hyponatremia, urine should be dilute. If you have concentrated urine with dilute blood, it is SiADH. If you have concentrated blood, hypernatremia, urine should be concentrated. If it is dilute, it is DI. Similarly, if you have acidic blood and your urine pH is high, what does it mean, Dr. Naveen?
So it means that the distal mechanism, which is the last pathway of H secretion, is also defective. So in that case, it pointing towards
distal artery. So in metabolic acidosis, if your urinary pH is less than 5.3, it is proximal, which is a normal response. If it's more than 5.3, this will be distal or rarely type 4 RTA. If you have infection, what will happen to urinary pH?
So in that case, it can become alkaline.
Because we discussed the urease producing bacteria can cause high ammonia and alkali urine, even if it is not an acidification defect. So whenever you're looking at urinary pH, you have to exclude two things. One is UTI, the second is dehydration, because that will also cause the same picture. So you need to have a normal urine RM, and urinary sodium should be more than 25 in that setting. Fractional excretion of bicarbonate, Dr. Vibha, as we discussed earlier, that anybody who is acidic should have how much bicarb in the urine?
For acidic, there should be no bicarb.
Should ideally be no bicarb. So if your bicarb is still there, it means there is a proximal RTA. So the prerequisite, however, is that your bicarb level should be above a particular level. If your bicarb is 12, you will have zero Fe bicarb anyway. So you should be doing it only once you have corrected acidosis. Bicarb should be more than 20. The measures basically are that you look at urine and blood bicarbonate, urine and blood creatinine. So it's basically urinary bicarb upon plasma bicarb into plasma creatinine upon urinary creatinine into 100, which is a simple standard formula which is there. If your less than 5% is distal, more than 10% is proximal. But remember, you should do it only when your acidosis is corrected, not when somebody is acidotic. Then there is no point doing in that regards. Now, what would be the best test to distinguish between proximal and distal is the urine to blood CO2 difference. What does it mean physiologically? What does it mean?
In the acidosis, there should be urine to blood ratio should be high, because CO2 should be more excreted in the urine in the acidosis.
Yeah. So basically, we are absolutely right. So body is wanting to push out. CO2 is a marker for carbonic acid. Let's put it this way. So blood should have a lower CO2. Urine should have a higher CO2. If the gap is not there, it means there is an acidification defect, which means it is a distal RTA. So urine to blood CO2 difference, as discussed, should be done during metabolic acidosis, not once you have corrected. So fractionation of bicarbonate after you have corrected, and this is before you have corrected. And very importantly, in that regard, you will measure both urine and blood CO2. And if it is low, which means you are not able to push out the acid, which means it's a distal RTA. If it's high, it is proximal RTA. So if you have a hyperchloremic metabolic acidosis, which has got a normal blood anion gap, a positive urinary anion gap, you then look at urine to blood CO2 difference. If it's high, it is proximal. If it is low, it is distal in that regard. So now the approach is very clear. Look at anion gap high, look at hyperglycemia, diabetic ketoacidosis, lactic acidosis, organic acidemia. Normal, look at urinary anion gap. If it's negative, it's a GI loss. If it's positive, look at potassium. High potassium is type 4 RTA, rare. Otherwise, look at urinary pH, fractionation of bicarbonate, and U2BCO2, which will give you whether it is a proximal or a distal RTA.
An 8-year-old boy came to our OPD, and he was born with a birth weight of 2.5. He was full term. It means there was no birth issue, and birth weight was quite normal. And he came with a complaint of failure to thrive since 4 years, as his father noticed that he is not gaining weight and height since 4 years of age, and he is having polyuria since 4 years of age. And he is also having on and off episodes of nausea and vomiting and abdominal pain, but they were not associated or aggravated or relieved by meals. There is a history of polyuria and polydipsia, but there is no history of any colorless and odorless urine. He has limb pain on and off, but there was no bony deformity and fractures. He has no history of recurrent loose motions, pica, or any reference to rise. No, he has no history of tuberculosis, edema, jaundice, and hematemesis, just to rule out any systemic illnesses. Any steatorrhea, constipation, recurrent respiratory infections, no neck flop, no episode of paralysis, and no history of lethargy, weakness, and hyperpigmentation. There's no significant history of any hospital admission and any treatment. Postnatal and antenatal events were uneventful, and he was a product of non-consanguineous marriage. Development were normal, and according to age, on examination.
Just hold on. So
yes,
you have
sir.
a child who presents you with failure to thrive and polyuria.
Yes, sir.
These are the two major
Yes,
things. What are the things you will think of?
So, if we go through the discussion that we have the like polyuria and the failure to thrive. They are more pointing towards the RTA, like anything else. Yes, sir. It could be like another tibulopathy, like Bartter syndrome. It could be like failure to thrive, like celiac disease.
Why polyuria?
So, in celiac disease, there is a like a multi-electrolyte deficiency. It could cause hypokalemia. Hypokalemia could cause polyuria.
More relevant. So, if you talk about polyuria, so you talk about things which can cause polyuria and things which cause growth failure.
Diabetes insipidus could cause like
diabetes insipidus
and this thing.
Diabetes
mellitus,
of course. It is a too long history, but you can't exclude that. So polyuria, diabetes mellitus will be number one. So
yes,
diabetes mellitus, so still long standing. Diabetes insipidus we've already seen recently. The same case is presented with failure to thrive. Then tubulopathy, which include RTA.
Yes, sir.
What else?
So any proper kidney disease like obstructive uropathy can cause. And
from an endocrine perspective, failure to thrive with polyuria, you look at the skin color.
This salt tasting, this adrenal insufficiency can cause.
So essentially, you are looking at either of these disorders which can cause polyuria with
failure to thrive. Yes,
so RTA. So we are talking about RTA, but you have to think of other possibilities also at that setting.
Yes. So there was no pallor, no clubbing, no cyanosis and edema. Facies were normal, no any midline defect, no bony deformities, no genovalgum and varus, and no organomegaly. And this vitals was stable, and this SMR
Why
was.
is blood pressure important in somebody who has polyuria and failure to thrive?
Sir, as we have discussed this, like in elevate hydroxylase deficiency, if there is a hypertension, that it was caused.
Anything else? Hypertension with polyuria with failure to thrive?
Sir, hypertension, polyuria, hypertension will always be accompanied by hypokalemia, sir. So in that case, we need to look for adrenal excess conditions, excess conditions, which can also cause hypertension and failure.
So apparent melanocorticoid excess, Liddle syndrome,
Yes,
all
sir.
those things will be there. And normal blood pressure, if you have hypokalemia, then you start thinking on Barter's and other possibilities.
Anthropometry, at the age of 8 years, his height is 106, which is less than -3 standard deviation, weight 14.7 kg, which is also minus 3.18 standard deviation. And on looking on the growth chart, is height for age
So it
is
is
clearly nutritional.
pattern.
This growth chart is showing clearly a nutritional pattern of growth failure. So on the differentials with failure to thrive and polyuria would be first, as I mentioned, like it would be diabetes mellitus, and second would be diabetes insipidus, RTA, Bartter syndrome. Sorry.
Okay.
Now coming to the investigation that we get.
So now in this setting, he is more than 3 years of age.
Yes, sir.
Would you be doing a blood? Why are we doing a blood gas? We said that isolated failure to thrive beyond 3 years is unlikely to be RTA.
Sir, but if we are having a failure to thrive with polyuria, then it is quite possible to have.
Rickets, but he has polyuria. So that is a very, very significant thing. So you have to look at that in that class.
Sodium and potassium normal, and as we have discussed, but it could be normal. And calcium, phosphorus, this TTG normal, thyroid profile, everything is normal. But on looking at this VPG, we found there was a pH was 7.19, bicarbonate was 15, and blood excess was -12. That was greater than that was less than -5, which is going in the favor of metabolic acidosis. Anion gap was normal. Urine pH was 7, that is greater than 5.3. It is alkaline. And urinary spot calcium create ratio was 0.54, which is greater than 0.2, and which is showing there was significant hypercalciuria.
So you have a hyperchloremic metabolic acidosis with alkaline urine
and with hypercalciuria.
So which means it is?
Clearly, it is showing that this is a picture of distal RTA.
What can be the reason for a falsely high urinary pH in this setting? Would you think of any condition which can explain that?
Urinary tract infection.
So you have to do two things. So before you look at urinary pH, what two things should be excluded?
So first is the urinary tract infection. Second is the volume, the hydration status.
So you should ideally, that would have been done at that point of time, is to look at urine RM, which has to be normal, and urinary sodium should be more than 25 or 20, whatever is in that setting. It's not dehydrated. Now, hypercalciuria, does it finalize this as distal RTA?
No, sir. We have to confirm it with the USG or whether there is a nephrocalcinosis or not.
Because hypercalciuria is, why does hypercalciuria happen in RTA?
Sir, because of this thing, proton is not excreted, so this some positive one has to be excreted. So along with
in exchange to sodium, you have to lose more calcium, more potassium. That is what will happen. So hypercalciuria is not unique for distal RTA. It will happen both in proximal also, which we discussed. And Naveen said because you have citrate urea, you do not have nephrocalcinosis happening here. But this urinary pH is very, very important.
Yes, sir.
Provided that the urine routine microscopy is normal and provided that the urinary sodium is more than 25.
Yes. On USG KUB, we find there was bilateral small renal calculi and fine medullary calcification in bilateral kidney and most likely nephrocalcinosis. So summary, we had a boy of 8-year-old with failure to thrive in polyuria with no bony deformity and fractures, with normal anion gap, metabolic acidosis, alkaline urine, hypercalciuria, and USG showing nephrocalcinosis. So the most probable diagnosis is distal RTA. On follow-up, we see that the child has grown pretty well. He has gained the height of 157 from the 106 centimeter and the weight of 45.5 kg after the getting treatment of 8 years. He has been with us since 8 years. And now the recent parameters at this pH has improved. It's like 7.3.
And what about the urinary nephrocalcinosis?
So they are still present.
So what will you do if you have persistent hypercalciuria in distal RTA?
So we'll give thiazide.
So what will thiazide do? How do they act?
So they act on sodium chloride importer, and
so
they decrease the sodium load, and
they decrease the sodium load.
They decrease the sodium load to the distal RTA. This distal tubule, and so there will be the less secretion of the calcium in the urine.
So basically, they are acting at an earlier level. So that will cause a sodium chloride issue. So in terms of that, your gradient, the electrochemical gradient is less. So the positive ion loss will become less in that setting. So thiazide, in a way, will reduce hypercalciuria, which is similar to what happened in Dital.
Yes.
So that's why we can use thiazide diuretics in this setting. Other clinical parameters, which will include the drug history, which is very important in hospitalized patient, amphotericin B, ifosfamide, lithium, topiramate. So topiramate, anybody with chronic seizures on topiramate can cause RTA. This is something you want to be aware of. Look at the eyes. Two things. If there are crystals, think of cystinosis. Otherwise, think of Sjogren's syndromes and Wilson's, of course, if you have the KF ring, which is present. Hearing abnormality. Now, in your case, you have to think of hearing abnormality, very important in all the three cases, because they all looked like congenital ones. So their hearing defects are very common in some forms of distal RTA, which is common. And if you have proximal RTA, think of other hepatic involvement, which is there. Look at glycogen storage, fructose intolerance, and Wilson's in that regard. So basic workup for distal RTA will include an ultrasound to look for nephrocalcinosis. I think all four of them had some, except for the one who was diagnosed very early. So nephrocalcinosis is very common. Proximal RTA we did not discuss because that's unusual at this point of time. Cystinosis and Wilson's, and type 4 more of aldosterone and PRA evaluation is required. Now, how do you treat? Distal RTA treatment is basically bicarbonate. And it is so simple that if you give appropriate bicarbonate, your potassium will improve, your bones will improve, your hypercalciuria will come down. So bicarbonate alone is effective in everything. Once you give bicarbonate, you will have a better improvement as far as volume is concerned, as far as acidosis is concerned, and the RAS axis will also be suppressed. So if your RAS axis gets suppressed, your hypokalemia will also improve automatically. So there's a lot of improvement which will happen. So they have hypokalemia at diagnosis, which improves with treatment. Proximal RTA do not have hypokalemia, but if you give them soda bicarbonate, they may actually worsen with treatment. Now, which alkali preparation to use? You can use sodium potassium citrate, but we generally prefer sodium bicarbonate, which is available as the tablets, which is quite good in that regards. Now, if we compare somebody whom you're giving sodium and potassium preparation, potassium will improve with both of them, but urinary calcium may increase with sodium. So this is you have to be careful about, because if you give more sodium, you have to get that sodium inside the body and calcium will be exchanged. So this is some point which is important. And of course, your volume will improve. So in that way, your RAS axis suppression will be better with the sodium. So both preparations have their advantages and disadvantages, which you look at, and hyperaldosteronism will decrease in that setting. So what should be your target? You want to maintain bicarbonate in the normal range, 22 to 24. The dose initially you will require, because there is already a deficit, you need to give for the first few days or a couple of weeks higher dose, and then you come down to 1 to 2 millimoles per kg per day. You can use sodium potassium citrate or bicarbonate as discussed. And if you have persistent hypercalciuria, then you have to reduce the salt intake, and thiazide intake is also there, and potassium may be beneficial in that setting. Monitor for urinary calcium, annual ultrasounds for hypercalciuria, and renal function is important in that regards. Now, one question which often happens is that if you have hypokalemia at diagnosis and you're giving acidosis correction, we know that acidosis, once you do, potassium will go into the cells. So what should we do? So if your potassium is below 3.5 and symptoms are there, you have to give intravenous potassium in that setting. If there are no symptoms, give oral potassium, and if there is no improvement, give IV. If potassium is above 3.5, start with sodium potassium citrate right away. Now, what will happen? So you have to monitor for growth, which is expected to improve. Bones will improve. Nephrocalcinosis may persist. So if there is hypercalciuria, you basically give thiazides in that setting. You may be precipitating the hypokalemic paralysis, so be cautious in the initial phase. Polyuria will improve. Rickets, acidotic breathing, everything will resolve over time. Priyanka Gupta is asking, can hypokalemia present with ileus constipation in RTA? Yes, so it can. If you have severe hypokalemia, you have seen patients who've gone on the ventilator directly, which is a severe areflexic paralysis like that patient that we discussed in the adult one. And of course, you will have ileus and constipation because they are hypokalemic symptoms and not specific for RTA. So it can happen in that setting as well. Dr. Pradeep is asking, can RTA present with ketonuria and glucoseuria? Glucoseuria, of course, if you have proximal RTA, you can have, but ketonuria is a very, very specific situation. It is not because of that. If you have ketonuria, you will expect to be either DKA or organic acidemia, which can cause that picture. Dr. Priyanka is asking, so again, the same questions, which was already addressed. So I think we've tried to cover 4 very interesting cases of distal RTA. We focused on distal RTA alone, but we had the whole spectrum from a young girl presenting mainly with failure to thrive, to a boy with failure to thrive with polyuria and renal complications, to a girl who was older with severe fractures and severe bone disease, and then the acquired cause because of Sjogren syndrome. So you need to keep your eyes and ear open with regards to distal RTA. Any child who is failing to thrive below 3 years of age, with polyuria, with rickets, with calcification, with hypokalemic paralysis, think of distal RTA. All you have to do is to look at the blood gas, has to be having metabolic acidosis with a normal anion gap, with a positive urinary anion gap, with a urinary pH which is more than 5.3. This becomes distal RTA. Treatment is very simple. Give bicarbonate, but monitor for hypercalciuria. If it is persisting, add thiazide diuretic, and then you will have improvement in that setting. Have a look at our website. Our tools are grand rounds. You can register for them so that you can update it on that. Look at our books and our mobile application.